also would like to thank the organizers for inviting my presentation. We're going to talk about a broad range of topics in a relatively short period of time, and many of which of those areas are somewhat controversial. And these are the topics that we'll be addressing. It's interesting. This is association studies looking at disappearance of dietary fat and country-to-country incidence of breast cancer from reports of 1968. So about a 50-year-old report suggesting an association with higher fat intake and higher breast cancer incidence. There were observational studies that provided mixed results and reflecting the difficult nature of determining dietary intake. Some of the food record data was positive, where you have an interaction. Some of the food frequency data was negative. And so finally, the NIH decided to go forward with the intervention trial, which was begun a while back in 1993. In the Women's Health Initiative, we randomized 48,835 otherwise healthy postmenopausal women, not particularly selected on the basis of their risk for breast cancer. They were randomized 3-2 to a dietary fat intake reduction regimen or control condition. Weight loss was not an intervention target. Interestingly, since the study was designed in the early 90s, the look at the data was based on time rather than number of events. Accrual took a little longer, so we had to look at the data about 18 months sooner than what we had planned in terms of number of events. But here's the result we had. Out of 1,727 invasive breast cancers, there were 9% fewer on the intervention arm, but the multivariate adjusted p-value was not significant at 0.09. You see the breast cancer mortality data was 23% less on the intervention, but again, with the p-value not significant of 0.07. On the right-hand panel, you see unplanned subgroup analysis looking at the incidence by baseline fat intake, where the women who entered with the highest fat intake had a statistically significant 22% lower breast cancer incidence. This study intervention stopped at that time of reporting, but now we're currently looking at 12-year follow-up data with analysis ongoing, which will be available later this year. A second study, which involved a smaller number of pre- and postmenopausal women, identified on the basis of breast cancer risk based on breast density, where women who were above a body mass of 27 were excluded, used a similar intervention. Again, dietary fat, not too much emphasis, with no emphasis on weight loss, and was really a completely negative study, as you see here, with a hazard ratio of 1.19. We got a somewhat different result when we looked at the same intervention strategy in patients with resected breast cancer. This was data that I presented at a plenary session at ASCO several years ago. This is largely postmenopausal patients with stage 1 to stage 3A breast cancer receiving standard therapy. Tamoxifen at that time for receptor-positive patients with or without chemotherapy. Most of the chemotherapy was before the taxane era, but CMF, adriamycin combinations. With the randomization of 40-60 to dietary intervention, targeting reducing dietary fat or control condition, again, reported at a mean follow-up of 60 months. And this shows a little bit of the problem in terms of doing lifestyle interventions. Here's on the left-hand panel, you see the baseline control condition, where there's complete overlap in terms of the distribution of fat intake. On the right-hand panel, you see that although we got a 4 standard deviation lowering of the dietary fat intake from 29.2 to 20.3%, you can see about a third of the women were actually having exactly the same dietary fat intake. Also on the bottom panel, you can see that even though weight loss wasn't a target, there was a statistically significant about 6-pound difference in weight between the two groups. Here's our clinical outcome, which was at that time with a hazard ratio of 0.76, with a multivariate adjusted p-value of 0.03, and that was at 60 months follow-up. The intervention and funding ended at that time, so there's no further intervention following this initial report. We've done one additional follow-up of survival analysis based on registry data, and you can see that in the right-hand panel, where again there were fewer overall deaths with a hazard ratio of 0.82, which did not achieve statistical significance, but again, in an unplanned subgroup analysis, the ER negative, PR negative group did have a statistically significant reduction in overall mortality. We are currently in the process of attempting a follow-up, now again after 12 years of intervention, 12 years of total follow-up, which we hope to be available later this year. So the hypothesis that emerged, at least from this study, was that a lifestyle intervention targeting dietary fat intake associated with weight loss may reduce breast cancer recurrence risk. The dietary pattern and breast cancer incidence issue is quite complex in terms of looking at not only one intervention, but associations with dietary patterns. And here's how there has been decided we can address this issue: Western unhealthy dietary pattern with the following components. Then you have a prudent, healthy dietary pattern, high fruit, vegetables, poultry, fish, low-fat dairy, and a Mediterranean diet, which is prudent, healthy dietary pattern with olive oil emphasis and some emphasis in some studies on nut intake. Though there's many criticisms one can levy over meta-analysis of addressing definitive results, I show them here because I agree with the findings in terms of looking at these results. And here's the modest association with a prudent, healthy dietary pattern, highest versus lowest category in a variety of observational studies. And you can see that there was a statistically significant but modest association with a fair amount of variability of the studies. When we look at the Western unhealthy dietary pattern, red meat, high fat intake, highest versus lowest in breast cancer risk, you can see great heterogeneity and an odds ratio of 0.99, really not a suggestion of difference in observational studies. When we look in the studies specifically looking at fruit and vegetable intake, when 20 cohort studies with almost 1 million women were followed for 11 to 20 years, what emerged was a suggestion that vegetable intake may be associated with ER negative cancer. That might be related to cruciferous vegetables. Again, these are the kind of data that certainly require further confirmation. You can see no significant association with fruit intake. The Mediterranean diet is getting increasing attention. The data are mixed with respect to cancer, but here's a meta-analysis again of the EPIC cohort of 335,162 women from 10 European countries with using this adapted relative Mediterranean diet found by questionnaire data, looking at high Mediterranean diet scores associated with lower breast cancer risk. Again, a modest association, hazard ratio 0.94, with the association stronger for ER/PR negative cancers. The data, like I said, have been mixed. In the Nurses' Health Study, a different issue had been raised where looking at 2,729 postmenopausal women with stage 1 to 3 breast cancer, so now looking at recurrence risk. And what they found was that women with low physical activity, so making several cuts, and higher Mediterranean diet were associated with lower non-breast cancer related deaths. So not with breast cancer deaths, but non-breast cancer related deaths. This kind of hypothesis goes with along with the suggestion from the New England Journal of Medicine randomized clinical trial reported last week, wherein over 7,000 women randomized to Mediterranean diet or not. They were all with high risk for cardiovascular disease. They had fewer cardiovascular disease and statistically significant reduction in overall mortality after 4.8 years of follow-up, giving the suggestion that perhaps Mediterranean diet may be associated with health benefits, but maybe away from the breast cancer issue. So what we're left with the diet is also a difficulty of separating out from other factors we'll talk about, including body mass index, weight maintenance and loss, and physical activity. Next, we move to vitamin D multivitamin use, again, a controversial area. Selective observational studies have suggested higher vitamin D intake and 25-hydroxyvitamin D levels were associated with, should be lower breast cancer risk, excuse me. And some recommend monitoring 25-hydroxyvitamin D and vitamin D supplementation to reduce breast cancer risk. The data have been mixed and no randomized trials were done. Again, the Women's Health Initiative came forward with a large trial, 36,282 otherwise healthy postmenopausal women randomized to calcium vitamin D supplementation at that dose and schedule 400 international units of vitamin D3. That was a currently recommended dietary intake. Mean follow-up of 7 years, and there was absolutely no influence on breast cancer incidence. Show here to point out one of the difficulties. When we look at about 2,000 patients in that study, where we're looking at their lowest to highest this is the lowest 25-hydroxyvitamin D level here. This is the highest. These are their diet and supplement intakes, and you can see there's tremendous overlap, including the difference between the lowest and the highest intake was only 258 international units. That's half a multivitamin. And we call attention to the fact that in the people that had this appropriately high 25-hydroxyvitamin D level, only 3% were taking above 1,000 international units of vitamin D3 per day. We do have a signal, however, that warrants further attention. These are association studies. One of the subsequent speakers reported the first association. These are a variety of cohort analyses, some from randomized trials, some not from randomized trials, but 4 of 6 studies show an association between higher 25-hydroxyvitamin D levels and lower breast cancer recurrence risk. Again, it's been very difficult to do such a study, since so many, especially in Western countries, since so many women are already on vitamin D supplementation. So that's what we would do. We would give vitamin D supplementation, not measure 25-hydroxyvitamin D levels. Again, this is a very controversial topic. Multivitamin use also is in the same category. Multivitamins have not been associated with breast cancer incidence in several reports. There's been concern regarding antioxidant addition, like vitamin E, with potential interference with radiation therapy and chemotherapy. These are very slight data, however, more hypothesis generating. But a recent cohort study in China showed breast cancer patients who used antioxidants had lower recurrence risk. So we're getting this mixed signal. I call your attention to this cautionary tale from, again, the Women's Health Initiative, where we looked at placebo adherence in our hormone therapy trials. So these are the women who are either taking or not taking their placebos in a randomized clinical trial setting. And what we saw in 26,000 women, this would be 13,000 women who are either adherent to placebos or not, we saw a lower incidence, association with lower death from all causes, lower hip fractures, clinical myocardial infarction, breast cancer, and cancer death, where we're actually controlling for most of the variables you think would be associated with these conditions. How about physical activity? Based on observational study findings, in my view, physical activity is the lifestyle factor most strongly and consistently associated with both breast cancer incidence and breast cancer recurrence. Here's a meta-analysis of 76 studies looking at breast cancer incidence in postmenopausal women. You see an odds ratio of 0.75 for postmenopausal, premenopausal 0.80, 20 to 25% lower, with really not much difference in intensity. The intensity being walking more than 3 or 4 hours seems 3 or 4 hours per week seems to be the intensity level. Again, a factor similar to weight loss, which will be addressed later. Here's another meta-analysis now emphasizing the prospective cohort studies. We're seeing the same kind of findings with maybe a suggestion that there may be more influence on ER, PR negative cancers. However, these are pretty consistent kind of findings that we're seeing. This latter paper raised some question about whether intensity levels do matter rather than having a threshold at 3 to 4 hours per week. I think as a medical oncologist, I'd be most concerned about influence of physical activity on patients who have established breast cancer. That is, if a woman gets breast cancer, does she change her physical activity? Does she change her recurrence risk? Here are 4 studies looking at physical activity after diagnosis, and they really show this very strong association of 24 to 50% reduction, association with lower breast cancer recurrence risk. One of the issues of those, of course, was the fact, does it relate to post-exercise or diagnosis exercise or pre-diagnosis exercise? And we addressed that with studies led by Melinda Irwin in the Women's Health Initiative population, where we actually had physical activity measured before and after breast cancer diagnosis. And what you can see here is that the women who had, the only women who showed a benefit were the women who increased their activity or maintained an active state after diagnosis. If they were active pre-diagnosis, it didn't help their recurrence risk. if they were active, if they were inactive and inactive, it didn't help their diagnosis. You can see only in the middle there are the populations in the multivariate analysis. Women who increased their activity post-diagnosis of breast cancer had an association with 33% lower breast cancer recurrence risk. In the era of targeted therapy and multi-thousands of dollar intervention strategies, I propose data supporting a less expensive intervention. So dog owners in a number of studies have been shown to be much more likely to meet their physical activity intervention targets. Propose giving a Labrador retriever to women on breast cancer diagnosis. At the time her chemotherapy is finished, the dog will be ready for walking. The cost will be approximately $1 a day for dog food. So we're seeking funding for such a trial. Okay. What do we have? So we've identified, and Pam will tell you about weight loss, but you can see we're building a theory that physical activity and weight loss may be associated with recurrence risk. What's going on? Here's some feasibility Vanguard trials. The WINS-2 looked at dietary fat intake, was successful, but it's not going forward. Energy USA, again, showed that weight loss can be achieved. The LISA trial is a randomized, all these were randomized trials in Canada and the US with 328 early stage breast cancers, showing that you can achieve increased physical activity and weight loss with associated laboratory changes, and that is being pursued as trying to go forward as a full-scale outcome study. But what do we have in terms of outcome trials? Well, we've got two full-scale outcome studies, which are unfortunately underpowered. And this is the one is the German Success-C study, which is built upon as a factorial design, a study in evaluating a taxane regimen question. And I should point out that this is the 37th taxane full-scale trial that has been conducted. And after 36 trials, I think we've learned that taxanes add between 12 and 15% to recurrence risk, and paclitaxel weekly may be better than every 3-week docetaxel. But in any event, this is going to be a phone-based intervention, which has really been completed with about a sample size of 1,000 patients, targeting reduction of body mass index and increased physical activity. The intervention is very similar to that used in the LISA trial. There's a lifestyle and breast cancer recurrence, Diana-5 representing a whole series of pre-studies involving, and you can see that they're targeting a higher risk population with metabolic syndrome, and mediating mechanisms will be discussed by later speakers in this symposium and also in the second symposium this morning. So looking at 1,200 women with, again, physical activity, weight control, weight loss being the intervention targets, and this study is evaluating a Mediterranean diet. Finally, we're getting near the end here. I want to make a case for why I think this is important. Here's two graphs recently published showing the age-adjusted breast cancer mortality rates from 1970 to 2010 increasing by over 100%. So breast cancer mortality increasing by over 100%. On the bottom of the same slide, I point out that in the same period of time in the United States, including the introduction of screening mammography, adjuvant chemotherapy, adjuvant hormonal therapy, adjuvant targeted HER2 therapy, we've decreased breast cancer mortality by 28%. So we have a big chunk in the middle, which almost certainly is related to lifestyle intervention, which is really receiving moderate attention. So my conclusions. Given available evidence, it is unclear whether any specific dietary component or pattern can influence breast cancer outcome if weight is optimal and moderate physical activity is maintained. Evidence for a potentially important role for weight loss maintenance, reviewed elsewhere later in this symposium, and moderate intensity physical activity in impacting breast cancer outcome is strong and compelling. Perhaps results from ongoing and planned randomized trials will lead to greater incorporation of lifestyle interventions in routine clinical practice. In the era of targeted therapy, lifestyle factors have demonstrated influence on pathways associated with breast cancer incidence and recurrence, which other speakers will address. Lifestyle change can be achieved at relatively low cost with centrally mediated interventions, which have been demonstrated to be effective and with minimal side effects. And increasing research attention to this area is warranted. Thank you. Genau.